On early versus late tracheostomy and brain injury. So I'm going to introduce Dr. Babi, who is presenting the earlier perspective of this. So Dr. Babi serves as a cerebrovascular center director for Cleveland Clinic's Florida's Neurological Institute. He also serves as a chair of ethics for the Cleveland Clinic, Florida. Dr. Babi earned his undergraduate degree from Cornell University and his medical degree from Weill Cornell Medical College. He completed his residency at the University of Vermont and his fellowship training at Duke University, along with an executive MBA at Duke University as well. He is board certified in neurology and neurocritical care and serves in his numerous leadership roles in the field of neurocritical care. So please help me welcome Dr. Babi.
Thank you for the introduction, and congratulations to the organizer for this very successful course, and thank you for inviting me. Let's start with an overview of Cleveland Clinic, Florida. We're part of the Cleveland Clinic healthcare system with an enlarging footprint in Southeast Florida. We're a 5-hospital system that spans from Fort Lauderdale all the way to Indian River, and the Cleveland Clinic is building a standalone brand new hospital in Palm Beach County, so that will increase our footprint to a 6-hospital setting. Please also join us in early November 2026 for our Cleveland Clinic Florida Symposium, The Future of Stroke Care in the beautiful Margaritaville in Hollywood, Florida. So really, the purpose of this talk is not just about, well, should we treat those patients early on or later on, but really looking at the trajectory of those patients and what is the value proposition, what is the quality care improvement that we can provide to those patients. So no doubt that a lot of us, whether stroke neurologists, neurohospitalists, or neurointensivists, have dealt with those type of patient population. Patient with structural brain injury, delay in the hospital. We know that those patients will likely not have early liberation from mechanical ventilation, and really become counterproductive and counterintuitive to just wait on those patients and decide, well, should we extubate them early or late extubation, when we know those patients do carry a pretty significant mortality and morbidity. So a little bit of backtrack about the tracheostomy itself and what is exactly for those who are not as familiar. It is a conduit for air delivery or ventilator management delivery. Some actually neurointensivists are pretty proficient at performing those at bedside. In the upper left side, as you can see, it's a piece of plastic device that typically surgically or at bedside inserted through the tracheo or cricothyroid membrane, which is right between the thyroid and cricoid cartilage. At the bottom left, you can see that is the tray performed. It's relatively straightforward for most setting procedure performed by the Seldinger technique. The reason I stress that, because it's not as bad as some can imagine, but most surgeons and a lot of neurointensivists are pretty familiar and proficient with the placement of tracheostomy in those patient population. So really the value proposition is not about should we do early or late tracheostomy, but we should look at really at the phenotype of patient that have trouble liberating from the ventilator and look at the right phenotype of patient population that are the right candidate for early tracheostomy early on in the course of hospitalization for a lot of factors that we'll cite later on. It is worth knowing that acute brain injury are very different than the broader cohort of critically ill patients. Our neuro-ICU patients, when they have extubation failure or difficulty to wean from the ventilator, typically in those patients is not a lung problem, is not a systemic problem in most settings. It is an airway mechanism problem. Those patients have impaired level of consciousness. They have impaired or decreased level of protective airway mechanism, trouble clearing their secretion or cough and agitation. And most of those patients will have difficulty regaining those airway protective mechanisms early on, meaning awaiting for those patients later at 10, 14, or 20 days to consider liberalizing them from the ventilator become really counterproductive. In medical or surgical unit, it's a whole different problem. Typically, those patients, not just typically, most of the time, they do have a relatively preserved level of consciousness, yet severely impaired lung, cardiopulmonary, or systemic problems. So it's mainly a gas exchange or compliance or oxygenation issues. But the neuro-airway failure itself is not a niche on its own. There are over 5 million ICU admissions annually in the United States, and we know that ICU beds are a limited resource in most hospital settings. Roughly a quarter to a third of those patients are neurocritically ill patients, and among those we have roughly just shy of 1 million stroke admissions, about 250,000 TBI admissions. And the reason I stress those two pathologies, those are structural pathologies, meaning when there are structural lesions in the brain that lead to impaired airway clearance mechanism or liberation from the ventilator, the chance of recovery early on in those patients is extremely limited. The end result, there's a huge cost concentration in this relatively important cohort with a disproportionate spend of those patients, approximately 800 plus million cost of hospitalization for those patients. Every ICU bed that those patients occupy is approximately $7,000 to $10,000 in terms of cost expenditure. So the problem is that there's a huge economic burden. It's not just looking at it from a cost saving, but there's a huge resource limitation of those patients. And a big resource liberalization in those patients is trying to free up those ICU beds, and a rate limiting step become ventilator management in those patients. To take it even to a different dimension, if we can liberalize 2 ICU beds in those patients by considering early tracheostomy in those patients that are not foreseen to be potentially extubated, that can translate in approximately $250,000 per patient, and roughly collectively, it's approximately 1.2 million ICU bed capacity release by considering early appropriate tracheostomy in those patients that have failure to liberalize of the ventilator. Fortunately, we have a lot of guidelines that support these pro arguments. The best guidelines come from Brain Trauma Foundation and anchored in severe traumatic brain injury, which is a pretty broad category of disease, including traumatic subdural hemorrhage, traumatic epidural, and traumatic subarachnoid hemorrhage. The guidelines do recommend as a high level, level 2A recommendation, that early tracheostomy is recommended in this patient category to liberalize of mechanical ventilation, typically when, of course, the anatomical and surgical benefits outweigh the risk of procedural complication. I didn't talk directly about that, but overall, the risk of procedural complication in the hand of proficient and competent proceduralists, which most surgeons are, tend to be fairly low. So in those patients, there is pretty strong data that do support, due to the structural nature of injury, early tracheostomy in those patients that have a pretty good chance of recovery in those patients, and will help in turn reduce the length of ventilator stay and reduce overall ICU stay and outcome in those patients. In the stroke patient population, the best data we gathered from the SET.2 trial, and as a background, there was a SET-point clinical trial followed by the SET.2 trial. That was a large multi-center trial that enrolled several hundred patients. But the drawback in those patient categories or in that trial design category, they included all subtype of stroke patients, included probably some patient that would not have needed tracheostomy in the first place, including also hemorrhagic and ischemic stroke. And we know the natural course of disease is very different when you have a temporal large hemorrhagic stroke versus a brainstem ischemic stroke. So the trial itself, looking at it at a face value in a severe stroke, was neutral. Yet when you analyze it, and I'll talk about it later in this slide, provide actually supporting evidence that in select stroke patient, early tracheostomy was favorable. In neuromuscular disorder, including Guillain-Barré syndrome, myasthenia crisis, myasthenia gravis, there is also evidence that prolonged mechanical ventilation in those patients result in adverse harm, therefore can include early tracheostomy in those patient population. But going back to the SET.2 trial, which is pertinent early versus late tracheostomy in patients with all subtype of stroke, neutrality of that trial does not per se mean that is negative, does not mean that those patients should be delayed in terms of tracheostomy. And looking at it from a 5-day early tracheostomy versus 10-day, in that there was no significant difference in modified Rankin scale at 6 months. However, when you look at the more severe subtype of stroke patient, those were the patients where there was early outcome difference in that patient population. It is worth noting that extubation failure is not a benign process itself. Most practitioners will consider at least one trial of extubation failure before committing patient to tracheostomy. A lot of us intensivists and neurointensivists have seen the catastrophic failure mode that can occur to patients that have high risk of extubation failure, including hypoxic event that can lead to adverse neurological outcome, but even worse, total hemodynamic collapse and cardiac arrest in patients that were otherwise predicted to have early risk of extubation failure. And we know those are the patient population that will likely benefit from early tracheostomy. Going back scientifically, there are certain neurological phenotype that would favor early tracheostomy versus late tracheostomy. Of course, patients with structural lesion, that lead to depressed airway protective mechanism, be it gag and cough. And why we mention that? Because those are the patients that have impaired airway secretion. We know those patients will benefit from early tracheostomy. Similarly, those patients that have had a history of extubation failure or difficult airway, those patients would benefit from early tracheostomy. And most importantly, the trajectory in the patient course. Is that journey acceptable to the patient and to the patient family? But then there are also some patients that probably are not the right patient population that you want to track early, especially those that have non-structural brain lesion. Patients with metabolic encephalopathies or status epilepticus or non-structural brain insult. Probably those patients are worth awaiting and seeing what is the trajectory, of course. Of course, when family are not aligned into the overall goals of care, especially in the more catastrophic brain injury, family is uncertain whether they would like their loved one to undergo the procedure, even the overall goals of care or potential transition to comfort care. Those are the patients that we ought not to rush in those patients, but really look at it holistically from a patient journey approach. Or if the procedure itself is unsafe because of a certain anatomy, neck anatomy, vasculature anatomy, or prior history of tracheomalacia or other airway problem, those are the patients we have to, of course, take a pause and reevaluate the whole totality of the circumstance. So in summary, why early tracheostomy help those patient population? There's, of course, less endotracheal tube burden itself. There is overall on the patient themselves specific reduce the endotracheal tube discomfort itself. So those patients require much less sedation. If we are to pursue early tracheostomy in those patients, there's less risk of laryngeal injury and tracheomalacia. Less risk of sedation in those patients, which translate, of course, into less ICU bed capacity in most academic setting. ICU bed capacity is a throughput and rate limiting step. So every ICU bed we're able to free, that's another patient we're able to take care for. Early mobility and communication, which is huge in those patient recovery journeys, not just the brain that we're trying to recover, but the totality of the patient. And early disposition, getting those patients to recover and early rehabilitation rather than delaying their discharge from the hospital and delaying the throughput while we're still debating whether those patients should undergo early or late tracheostomy. So there's a practical roadmap. We can look at it practically when we manage those patients with acute severe brain injury, what to consider the tracheostomy within the journey of their care. Of course, the first 48, 72 hours, we still try to understand the disease process. We're trying to stabilize the acute brain injury process, but early probably starting daily spontaneous breathing trial in those patients in readiness. Really, that clinical decision about tracheostomy time should occur within this 3 to 5 days. Are those the patient trajectory that we talked about earlier? There's a good prospect to recovery. Most importantly, that journey is acceptable to the patient and family. Now is consulting the surgeon or the interventionist that can perform that tracheostomy and looking at that specific phenotype. Really, by day 7, we should not be debating, well, does the patient need tracheostomy now? By day 7, we are looking now already at the post-hospital recovery phase, rehab, acute rehab, and what needs to happen beyond hospitalization. We can even take this to a further a national platform. There's actually very little that was done from a quality improvement process, but looking at it from a 2 very different cohort in those patients specific to the neuro-ICU population in terms of early tracheostomy in those patients whom that journey is acceptable versus late tracheostomy. Of course, the counter arguments are very anticipated in light of the conflicting data. The biggest counter argument we hear from the SET.2 clinical trial was that this trial was neutral, looking at it from the optic of stroke itself. Sure, if you look at it at a face value, collectively it was neutral, but it did not look specifically at the patient journey itself in the severe stroke patient, and not every phenotype fits it all in this patient population. The other counter argument was that there is a procedural risk in those patients. The quoted procedural risk in tracheostomy tend to be in the low single digit, but we know that extubation failure, anytime you also have a delayed discharge from the ICU, there's a proportional increase in risk of ICU-associated nosocomial complications such as infection, ventilator-associated pneumonia, other ICU-related injuries. So the counter argument is that indeed every time we're able to reduce avoidable length of stay in an ICU setting, we're actually helping those patients. So really the ultimate closing verdict is that the right question we should pose ourselves is not just early or late tracheostomy, but really looking at it from the optic of the patient themselves. Has the airway trajectory declared itself? And the airway trajectory is that those patients that have severe structural brain injury and the journey is acceptable to the patient, then indeed early tracheostomy is indicated in those patients. Importantly, we need to measure some tangible outcome for those patients. Tangible outcome, avoided unnecessary ICU days, avoided unnecessary ICU-related complications, and most importantly, getting those patients into their communities through rehab and integrating them back in their post-acute brain injury recovery journey. With that, I want to thank you all, and I'm here to take any question. Thank you.
Thank you, Dr. Babi, on presenting that early position. We'll invite Dr. Goswami up here to present the late, and then we'll open it up for questions. So Dr. Shweta Goswami is a neurointensivist and critical care encephalographer at Cleveland Clinic. She received her neurology training at the University of Kansas Medical Center in Kansas City, followed by fellowships in neurocritical care and critical care encephalography at the University of Florida. She is board certified in both neurology and neurocritical care and is heavily involved in national societies such as SCCM, NCS, and the American Clinical Neurophysiological Society. Please welcome Dr. Goswami.
Hello, everyone. So my job is to try to convince you to maybe take a pause and think carefully before we proceed with our patient getting that tracheostomy in the early stages of their ICU stay. I just wanted to give a little full disclosure as part of this debate. Dr. Babi asked me to give him my slides, so he's had access to my slides, but this is the first time I'm seeing his. So take that into account when you guys are voting whether or not our patients in our neuro ICU deserve to wait a little bit before that tracheostomy. So, as Dr. Babi rightfully pointed out, it's a little bit less about the procedure and more about the trajectory of our patients in the neuro ICU. And I'm going to help you see in the next 10 minutes why waiting before tracheostomy and acute brain injury makes the most sense. Let's start by defining what late means. Late means in these studies between 7 and 10 days. In a patient's ICU stay in the neuro ICU, that's a relatively short period of time. We have patients routinely here for weeks on end while we're investigating the reason for their acute brain injury. Think about a subarachnoid patient in vasospasm window for about the first 14 days of their potential ICU stay. Late tracheing is still within that early realm of what would be their prolonged ICU stay potentially with us. And to recognize also in all of these studies, there's a lot of practice variation. The tracheostomy rates in severe TBI ranges anywhere from 8% to up to 50%, and it's a big heterogeneous group of people. And as Dr. Babi also pointed out, the only recommendations that exist come from the Brain Trauma Foundation's guidelines that recommend level 2A to think about tracheostomy early in the traumatic brain injury population. And their argument for it is because of shorter ventilation and shorter ICU length of stay. Those with traumatic brain injury with high likelihood of survival. First of all, that does not include all acute brain injury. And second of all, the information that they're basing their recommendations from come from 2 studies with populations in the 60 range. So we're not looking at large, robust data to even support early tracheostomy in traumatic brain injury. The only trial that's really tried to think about all of our patients' heterogeneous disease etiologies is the SET.2 trial, which Dr. Babi also highlighted. And what they found in the SET.2 trial was that there was no difference in functional outcome or mortality. And he kind of scooted through this fact, but I wanted to pause and really highlight the other thing that SET.2 brought up. 22% of patients in the standard trach group, those that were in that 7 to 10 day range to ultimately make the decision whether or not we need to proceed with tracheostomy or a trial of extubation, were successfully extubated and completely avoided the need for that trach to begin with. I don't know if you got a chance to get the visualization that Dr. Babi highlighted about a trach, but there's a lot of stuff going on in the neck. I don't know that I want to subject somebody to a trach when there's a large trial that's already highlighted. Nearly a quarter of those patients, if we had waited it out to 7 days, they could have avoided even conversations with thoracic or trauma or the bedside neurointensivist in getting that tracheostomy in the first place. Versus in the early group, that less than 5 day group, where only 1.6% of those patients avoided tracheostomy and were successfully extubated. And they found that when they did subgroup analyses, that it didn't matter the kind of stroke that the patient presented with, their age, their sex, or even their GCS score. So again, highlighting the need to maybe think about the trajectory of our patients, the etiology of the reason of their ICU stay, and that maybe waiting that 7 day mark isn't that big of a deal if you can save a quarter from even needing a trach in the first place. When thinking about it in summary by pathology, recognizing that really the evidence exists in mostly meta-analyses done retrospectively, and most of them emphasize this shorter need for the mechanical ventilator, the shorter need for ICU length of stay, but really no clear benefit for mortality and not really any clearer benefit from a functional outcome standpoint. And we have a lot of different patients that suffer acute brain injury. Really, the modest benefit for mortality have been mostly in the general ICU patients, where most of these people are dealing with reasons for intubation being unrelated to any sort of encephalopathy or brain injury. So the bottom line really is that we don't actually have any patient-centered outcome that supports putting a trach in the patient within the first 5 days of their ICU stay. And it would be important for us to recognize that the largest trial, SET.2, that looked at our patient population found that a quarter of them actually avoided a trach altogether throughout their ICU stay by just waiting and watching their disease trajectory. And to also recognize something that Dr. Babi highlighted, the peri-procedural adverse events in SET.2 was 15.8%, including venous bleeding, aspiration, pneumonia within 48 hours after getting that tracheostomy. So this is not benign stuff based on the data that's present. Now, that doesn't really leave us with a lot of information clinically to decide, all right, so do I just wait 7 days if they don't clearly look like they're ready to be extubated? That's it? I just call for the consult and get the trach and peg placed? There's actually more there. There's quite a few validated prediction tools that kind of address really the two questions that we have when our patients end up on a mechanical ventilator. First is, will my patient with acute brain injury need a trach? And the second question is, will they potentially in the future be successfully extubated? And those are the two things that we really should be thinking about in determining clinically which direction to go. There are two tools that look specifically towards predicting tracheostomy need, the SET score and the neuro-ICU nomogram score. And then there's a whole host of them that try to predict some sort of extubation failure, thinking about maybe waiting a little while and then ultimately deciding whether or not tracheostomy makes the most sense for our patients. And in the interest of time, I won't go through all the detailed stuff, but I think a practical approach is to identify high-risk patients that really would benefit from that trach right then and there. I think a lot of traumatic brain injury patients fall under that category because of polytrauma. A lot of times they have a lot of facial trauma, a lot of other things that need to be addressed in their ICU stay, and it would be a lot easier to manage the patient if we went ahead and secured an airway for them as they proceed through their disease trajectory, versus those that are coming in with an ICH at the worst clinical state that they're in, watching those disease trajectories and recognizing that there are then validated tools to try to help us assess, well, will they fail extubation or is it time to give them a try? And of note, of all of the prediction tools that try to predict whether or not extubation will be a failure, the return of cough and swallowing function seem to be the strongest prediction of extubation success. Not necessarily GCS score, wakefulness, things like that, but just really, are they making any attempts to swallow, and is their cough back? So I'm hoping this works, but I had a couple cases because I'm so curious to hear everyone in the room tell me whether or not they would trach this patient, wait a little while, or proceed with an extubation attempt. Is there a way to see if this will work? Do I just keep moving forward? Some slight technical difficulties, but I'm also happy to just do a little interactive raise your hands. Are you guys able to tell me back there if we're going to have Slido or not for these cases? No, not going to work. Yes, I can read from there. Thankfully, my glasses are giving me an edge here. All right, so first case, we have a 54-year-old gentleman. He has a Hunt Hess. Oh, can you leave that? I need to be able to read the cases. Yeah, I can also look. Let me see. Case is a 62-year-old woman. She's got a large right MCA stroke. She's now post-intubation day 4. She's awake. She's intermittently opening her eyes, inconsistently command following. She's got a moderate cough, minimal ventilatory settings. So she's on a pressure support of 8/5, FiO2 30%. But she's got thick secretions requiring suctioning every 2 hours. Is this somebody? Let me see a raise of hands. Are you going to trach her? Anybody for just traching her? Maybe. I got a maybe. Maybe traching her. That's a good question. It's right MCA. You know, let's say, you know, she's got some cerebral edema. I don't know, 5 millimeters. Every 2 hours. Okay, another trach. How about time? This is day 4. Time. We got some time. Time. Anybody feel like extubating her today? Dr. Donnie feels like extubating her today. All right. Okay. That's interesting. All right. Next one. 54-year-old man. Aneurysmal subarachnoid. Hunt has 3. He's post-coil day 7. He's in the spasm window. No clear evidence of spasm quite yet. During a spontaneous breathing trial, he became pretty tachypnic, up in the 30s respiratory rate. He's pretty agitated, pulling at lines. He's oxygenating really well, though. You know, SpO2 97%, FiO2 30%. He's got some secretions. They're about moderate, but he's got a present cough. It's not, you know, it's not a great cough, but it's there. You can sense that he's got it. Can I get a show of hands of we're going to trach him? We're going to trach him. Okay, I mean, this is day 7, guys. Come on. How about we give him some time? Okay, a lot more hands showing time. What about we're going to extubate him today? Okay, we got some extubation people. Okay, interesting. All right, and then the last one. 58-year-old man with a pontine hemorrhage. He's now day 5 post-intubation. He's awake. He tracks his family members with his eyes, and he can follow some simple commands with his left hand. He's got an absent gag and cough reflex, but minimal secretions. All right, are we going to trach him? Okay, a couple. Oh, okay. Yeah, majority, it looks like we're going to trach him. Are we going to extubate him? No one's going to extubate him. Okay. Are we going to just give him a little bit more time? I mean, he's day 5. Okay. Yeah, so I think really just trying to highlight that this is really nuanced. And I think that's the theme you're seeing from all the things that the neurointensivists do, is that we make nuanced decisions that are very personalized. And so it really isn't necessarily early versus late, but it's thinking about that patient and the strongest predictor for them succeeding in extubation and what is going to help their trajectory and functional outcomes be the best. Thank you, everyone.
Okay, if we can invite all the speakers back up here. I know we're a little bit behind, but if we wanted to have questions regarding the early versus